Thanks, Narelle. Thank you, Ahmed, and the team also for inviting me to talk. I think John's preceding talk was a nice lead-in for this. I'm going to be talking about the role of single anastomotic gastric bypass. That's a bit of a mouthful. I'm going to use mini bypass for the talk today. Mini bypass, single loop, and mega bypass are all the same operation. I'm going to talk a little bit about the evidence for this operation, where it fits in the current landscape of Australian surgery, so particularly where the evidence lands is for the sleeve gastrectomy. For the non-surgeons in the audience, my laser doesn't reach that screen, but essentially from a mechanical point of view, the operation involves cutting the stomach down to a thin tube, similar to the sleeve, about 2/3 as long, but instead of going all the way to the end of the stomach, we unhook it from the stomach and join it to the small bowel, about 1.5 metres to 2 metres downstream. So the fundus residual part of the stomach remains, so theoretically it is reversible. Now, where does this fit in the paradigm of our current operations? I'm going to compare it primarily to the sleeve and the Roux-en-Y. I still offer band. Talking to George Hopkins earlier, I do about 1% of my operations are a band, probably less than that now the last couple of years. Essentially, the single loop bypass in a nutshell offers the safety of the sleeve operation for initial surgery, and there are issues down the track, but without the complications of the gastric bypass, yet it brings a lot of the metabolic and more durable weight loss results of the gastric bypass. We'll go into that in a little bit more detail. As far as the Australian landscape at the moment, that, and I'm sorry my pointer doesn't work, that little green line there, third from the top, is the single loop bypass or the mini bypass. You can see the numbers have increased the last couple of years, but it's relatively stagnant. You can see the bright red line there is the band. That's decreased as more surgeons outside of Victoria have got onto the bariatric surgical registry, and sleeve numbers have gone up. But we're still only capturing probably about a quarter of surgeons at the moment. And if you look at where the vast majority of procedures are done in New South Wales, Victoria, New South Wales, Queensland and WA, we're still only getting 30 to 50% of the bariatric operation. So we have to take this a little bit in context. As far as primary operations go, bypass operations now are more than sleeve, are now more than band. You can see sleeve is by far and away the most common operations. You can see the bypass operations, however, are close to 50% of the operations done for revision surgery though. As far as my practice goes, taking on the single loop bypass or mini bypass, the last 3 years has certainly increased my number of bypass that I'm doing as a percentage of my operations. It's now just over 40% of the primary operations, and of all the bypasses I do, well over 90% are single loop rather than a Roux-en-Y. It's also probably my preferred operation for revision surgery for failure for weight loss with band or sleeve patients, the latter without severe reflux. We've got to go back then and look, where does it fit into the sleeve? Why would I consider doing this when I'm already doing a sleeve that's achieving reasonable outcomes? Traditionally, the sleeve didn't achieve as good a weight loss after 1.5 years with the Roux-en-Y. This is a meta-analysis we can see, and didn't get as good as diabetic results. It was, however, less complicated to do with less complication effects in terms of morbidity procedures. But most of the data relates to sleeves where they didn't do an antral resection. And that was particularly the case in North America, South America and Europe. There's only small areas like Jasart and Serangoon and Seattle, you would do an antral resecting sleeve. We know with this type of sleeve, we leave less residual stomach, less likely to dilate up, and theoretically we should get better weight loss results. There's now one randomised control study that shows that, with better, superior 2-year weight loss results, and also decreased risk of weight regain, quite a significant difference at 2 years. There's also a cohort comparison showing similar outcomes. My outcomes in my patients with a sleeve at the moment, we look at primary patients, weight loss peaks at 1 to 2 years. There's a bit of weight regain between 2 and 4. And as far as we can tell, beyond 4 to 5 years, we're talking about follow-up, I only know it's going on with 55 to 50% of my patients at that period. That's despite having a research nurse ringing these patients. We still have reasonable weight loss, but there is a big standard deviation there, and there's not all the patients in that group are entirely satisfied. Really poor weight loss outcomes are rare. Less than 25% excess weight loss is less than 6 to 5% of the patients. So what happens with a modern sleeve? With a modern sleeve, there's a Stampede study that most of you know well. We know that the sleeve and Roux-en-Y bypass achieve similar outcomes in terms of diabetic control. This is 5-year data. Likewise, we look at even more modern series, looking at weight loss outcomes. At 3 years, there's no difference between a good sleeve and a Roux-en-Y gastric bypass. Likewise, pretty similar outcomes and comorbidities, particularly in regards to diabetes, the only exceptions being lipids and also, as we'd expect, reflux results that are far superior in the Roux-en-Y. And when I look at my results for more than 1,000 sleeves and more than 300 bypass, at the moment we're seeing similar results out to 2.5 years in terms of weight loss. Has to be taken with some caution because the revision rates, or the patients having revision surgery, a lot higher percentage of the bypass group, almost 10 times as much. So mini bypass, where does this fit in? Since 97, the numbers of this have been increasing quite dramatically around the world. But Rutledge in North Carolina is the one who promoted this and really stormed the scene in the early 2000s with his own sort of brand of marketing this operation. You can see his first large paper published here that's entitled Continued Excellent Results with the Mini Gastric Bypass. He's not one for understating the good results and maybe a little bit glossing over the bad results. But there's no doubt he's got excellent weight loss results and good early safety. There are, however, issues with nutrition. Not surprisingly, he attracted a bit of criticism. One of the papers published from 5 surrounding units in his state found patients with complications from this operation. They wanted to bring it to our attention that maybe there is more to look at with these operations in the long term before jumping in. However, larger studies from around the world, particularly Europe, have been able to show similar results. So it's got good initial safety and no doubt there's good efficacy in terms of disease control and long-term weight loss. There's another study from Spain with really good follow-up at 7 and 12 years showing exceptional long-term weight loss. They did have a longer bypass than what we had, but they had relatively low long-term complication rates. Likewise, from Italy, another recent paper with well over 2,000 patients showing good initial safety. But at 5 years, so big numbers through 5 years, 683 patients, a long-term complication rate of 10%. And they've overstated the complication rates here. 4% of patients had reflux, but only half of that group required surgery for reflux. 0.7% of excessive weight loss, and they noted that occurred more when they had a long limb. They had anemia, but they had very low rates of weight regain. We look at the literature as well in terms of comorbidity resolution. It's pretty consistent for the mini bypass, 95 to 85% resolution for diabetes, and that seems to be the same for hypertension, hyperlipidemia, and sleep apnea. And the reflux, where it has been looked at, there's a lot of concerns about reflux with this operation. Mostly it will improve. Another cohort comparison from India this time, so rather than just cohorts on their own, they had a high mortality rate for sleeves that we certainly wouldn't tolerate. But they were able to achieve, despite having high mortality rates with the sleeve, good results with the mini bypass. They had low leak rates with that in the Roux. Surprisingly low reflux results. And I think the more we look at this operation, the reflux results are not disastrous by any means. Weight regain was also very good. They did, however, have a very high issue with low protein with the mini bypass group, and this is important stuff. They noted again when their BP limb was over 250 centimetres that they had problems when they reduced it. That went away. Rest of the results favoured mini bypass. Another cohort comparison, this time from a separate unit from India, all with 5-year follow-up for sleeve and bypass. At 5 years, better weight loss and better reflux result with the mini bypass, as we've come to expect looking at this other data. Lee Wei, sorry about my slides, didn't transfer from the Mac to the PC perfectly. It's got a huge experience from Taiwan. Again, less complications, shorter operating time with the mini versus the Roux, and better 5-year weight loss results. Pretty similar late revision rates, same comorbidity rates. Gastrointestinal quality of life was very similar, less pain with the mini bypass, but more diarrhoea. And as randomised control studies showed pretty much the same effect. There is an issue with malnutrition. If you're thinking of taking this up, you need a good team, you need to keep an eye on your patients and you need to be cautious. A big review of surgeons doing a survey found rates similar to that in the literature. It's probably double what it is in the literature, it's probably 1%. We know the longer the limb length, the higher the risk. The shorter the limb length down to 150 centimetres, which lots of surgeons are going to, you're going to get less issues with that. And I don't think 0% is accurate, but it's going to be less of an issue. Patients can die down the track if they ignore these issues. This is a really rare case that's published. The patient had unusually short bowel. They only had a 100 centimetre common channel. I check all my patients now have a 3 metre common channel before I do the anastomosis. My technique, there's nothing special about this. I use a long thin pouch. I use 140 to 200 centimetre bypass. I've tapered down as I've got more familiar with the literature in my patients. The super obese get a bigger one, the older and more frail get a smaller one. I do a 30 millimetre routine tan anastomosis unless there's a recent history of smoking or a bit of tension. Results so far are pretty similar to my sleeve and bypass patients. The major difference being the resolution of diabetes, 85% in the mini patients compared to the sleeve patients, 65%. If we look at the primary patients, there's a trend away in the mini at 1.5 years, but it's pretty early days. With the super obese, again, it's pretty early days, but a bit of a trend away at 1 year mark for the mini. And if we look at revision surgery, it's pretty much the same for mini, Roux-en-Y and sleeve. Acute complications with the anastomotic technique I use, including for the Roux patients and the gastric cancer operations I do, I'm yet to have a leak yet. It's probably the next one's coming to hospital as we talk. With primary surgery, reoperations, I've had one patient early on with minor contamination at the top of the sleeve, and two very recent ones, both due to things I do to prevent problems. One was a obstruction of the biliopancreatic limb due to a tight fat wrap, which was released laparoscopically and settled very quickly. Another patient, we took all the fat out of a large umbilical hernia, and the patient had small bowel slip up into that 3 weeks later. One patient's had a leak from the top of the sleeve where we did no surgery other than reduce that from a hiatus hernia from patient converting from sleeve to bypass, and they were treated with conversion to a Roux, which I think is your get out of jail card. And you need to be able to know how to do a Roux well if you're going to do this operation. If you've got significant contamination like this patient, you need to go to the Roux. As far as late revision, I've only had one patient so far that's had reoperation for reflux, and they'd had a previous sleeve. We've had one patient have reversal, my fellow said, for excessive flatus. More than anything else, nutritional values weren't a major issue, but they no doubt had significant diarrhoea. And they opted, even though they had a really short common channel, they opted for a reversal. They still have a Magenstrasse and Mill type operation. As far as safety goes in the bariatric surgical registry, as best we can capture complications on that, it seems to be quite equivalent with the band and the sleeve for initial results. Revision operations, the risks go up for all operations, but it's certainly comparable. And as far as late operations, we aren't finding huge numbers in the Australian database so far. So I think the mini bypass is here to stay. As you get more skilled surgeons comfortable doing bypass anastomoses, the numbers are definitely going to increase. We definitely have durable weight loss with it. We've got excellent comorbidity resolutions. But you have to be mindful with your management of these patients long term, and I think with a lot of things that John was talking about, that the rare nutritional and hepatic issues they have to be aware of. And also you've got to be very conscientious about your patient management. Thank you.
Thanks, David. Time for a couple of questions. Ahmed.
Thanks. I don't want to hog the microphone, but I guess it means I'm not asleep. Thanks, David. John's telling us that a big series of Roux-en-Y gastric bypass, 400 cases or so, neuropathy or thiamine deficiency perhaps in up to 16%. And you're looking at a malabsorptive procedure and reporting 0.5%, maybe 1% if that's underestimated, of long-term complications, anemia of less than 1%. I reckon anemia in the preoperative group is higher than 1%. How do we account for the discrepancies?
Well, I think what they're often referring to is severe malnutrition requiring reoperative surgery. Anemias, you're going to get up to 4 to 7% at least, but a lot of these patients are being replaced and monitored closely, and they're the patients who come back to clinic and get on the database. So there's no doubt the patients who don't come back to clinic, we have a problem in this country. And I've got another slide that I didn't bore you with today, but I've got 3 GPs that help me look after the patients. They send an email after each clinic. Everyone gets a copy of the email so you know what's going on. We have a nurse ringing these patients full time, and we have the nurse chasing all the blood results. We have an expert dietitian, expert psychologist. The dietitian oversees the nutrient issues. We've also got access to 2 good tertiary public hospitals that I work at, so we have acute issues looked after, and that's still not perfect. But I don't think you can be taking these operations on in decent volume without those sort of backups.
George.
Thanks, Marto. How many of the band to single loop, was that about 7?
A band to single loop. So there was I think there's 28, 30 revision operations for mini.
Yeah.
I don't know. I think it's maybe 15, 20. And there's sleeve group and there's sleeve and band. Yeah.
Any issues with, I've certainly had issues with the top end of the band obviously being a bit more distorted. As you described, sitting above a long, narrow pouch. Have you had any functional issues, which I have had, where the sort of atonic top end band-related pouch sitting atop the sleeve-like pouch, where it doesn't function terribly well. Have you had to convert any of them?
None.
No?
But and we've got a decent, Craig and I think I'm not sure if someone's presenting at this meeting, a band to sleeve experience, but as you know, we're not as game as you to George. We do a 2-step procedure, whether that makes any difference or whether we're just waiting to find the problem, I suspect. Do we have enough? Are you asking another question?
No, I was just going to make a comment about your shirt.
Yeah, but thank you. I know it's going to be good. You don't need to say any more. Narelle, can I ask a brief question?
Yes.
Yeah, Dr. Higa, could I be so bold to ask, is it just the insurance issue in the States why this procedure isn't starting up? Is it just the personality of the pioneer? What are the affecting factors?
If I were an attorney, I'd say asked and answered, right? I mean, so yes, it's a combination of both. I mean, I look at the literature as well as anyone else. It looks very good. It's an operation I think is an evolution of a gastric bypass. Has many advantages and has an addition. Something that you kind of alluded to was ability to modify the operation according to the needs of the patient, which is difficult to do with the standard Roux. But the inventor is somewhat controversial, and it puts credibility to risk on some of the early studies. But since then, randomized controlled trial, YJ Lee, et cetera, it all looks pretty good. But for us, we don't have insurance ability to do it. It's all out of pocket. And we don't do that kind of things there. There are other individuals within the United States who are doing these operations besides Robert Rutledge. I don't think he's doing much in the United States anymore. And and from the IFSO side, from the national side, we're very interested in looking at this, and we're going to come up with, we're actually working on a position statement as we speak. So,
Thank you.
Thanks, David.
Thank you, David.